Hello, today we are going to talk about additive composite bonding as discussed in article published in Dental Update in January 2025. This article is important from exam point of view in IMM as you can get a long question or in FCPS Part 2 operative dentistry exam when you are going for treatment options and again in short essay questions. This article is also important for the point of view of overseas registration exams and other exams like this, in which they will just give you clinical pictures of a case like this, and you will be asked to present the treatment option or counseling or anything like this. So let's go forward with it. Here we see the abstract of this article. This article was published by Martin Kelleher, Will Donovan, and Nadina Safi. If you want to go through this abstract, please pause the video. In the introduction of this article, they have discussed three problems. First problem is that there is no consensus on permanent restoration of the root canal treated teeth. Another problem is that these root canal treated teeth are restored according to their existing occlusion. And this existing occlusion is the main culprit, which is the causing the damage to the tooth, resulting in pulp exposure or carious pulp exposure or fractures of the tooth and requiring root canal treatment. The remedy they have presented to us is that we should consider the harmful occlusion and do the additive composite bonding. By considering the harmful occlusion, we are not going for the full coverage restorations. We are going for partial crowns for endodontically treated teeth and doing additive composite bonding on the teeth that are adjacent to that restored tooth or endodontically treated tooth or in the opposite arch of the endodontically treated tooth. Here they are showing the function of additive composite bonding done on the opposite arch. As you can see on the left, there is an image which is showing that there is reduced dimension for of the reduced vertical height of the tooth, and OVD has collapsed. And on the right side, you are seeing that additive composite bonding here is represented by red lines on the upper molar, which causes the increase in OVD and occlusal reduction for any kind of restoration for endodontically treated tooth requires less sacrifice of the precious dental tissue of that root canal treated tooth. Then there are next two sections of this article, in which the first section is the communication, in which they say the patient should be communicated about benefits, risks, and doing nothing termed as brand. Then they mention that there is nothing permanent in dentistry, or rather in life. There are no permanent teeth, no permanent restorations. Then they say that 4 to 6 weeks of adaptation must be quoted to the patient so that they do not reject it outright. And if they accept this mode of treatment, there should be proper documentation mentioning to the patient that these restorations will need to be repaired, and there is well documented follow up of 6 years or more. Another thing about these type of additive composite bonding is that the teeth which are suitable candidate for this additive composite bonding should be periodontally stable, and they should not have post and core restorations in them. And from the consent point of view, they have mentioned several terms such as dental capital, which is the remaining tooth tissue, self preservation, which means that a treatment that is conserving the tooth tissue. Self resection means the patient has taken any extractions which cause the loss of the precious dental capital. Self-improvement is the improvement of teeth such as bleaching or microabrasion, which does not cause self-destruction of the dental tissue. Here we come to the case scenario 1, which was a 53-year-old male presented with root canal treated tooth in left lower first molar, and the OVD was collapsed because of attrition and abrasion on upper anterior teeth, as you can see on the left side. I cannot post actual photographs here due to obvious copyright reasons. Then they are going to do post and core buildup for this tooth. For the post and core buildup, they have used glass ionomer cement in two consistencies. First, they mix the glass ionomer cement in thin consistency. Dab this thin consistency glass ionomer cement onto the self-threading titanium dentine pins. The dentine pins, the channels of these dentine pins were prepared with a slow-moving diamond burr, and when these pins were inserted through the slow-speed handpiece, when the resistance fall felt and the pin was being inserted, they would stop. They would not insert the pin fully into the channel, and then they let it. Then they let the thinly mixed glass ionomer cement be displaced by adding more powder to the already existing thinly mixed GIC on the glass slab, or rather a mixing pad, and make it a thick doughy consistency and insert it into the canal, rather into the preparation. Then it is allowed to harden or set, and your core restoration is prepared. Why this core restoration was necessary? They said in a healthy patient, if there is no core restoration, the OVD you have gained, the space you have gained for the final restoration, in this case, it is a 3/4 metal crown. If you gain the space for this tooth, if you do not do any core or any temporary restoration for the tooth, the TMJ will go into the fossa superiorly and posteriorly, and all the vertical height you have gained by reducing the tooth will be lost. So this core was necessary, and temporary restoration placed on it was also necessary. In this case scenario 2, there was a 20-something years old female who has lost her left lower first molar through root canal treatment of the cracked tooth, and she wanted the white tooth restoration. But for the white tooth restoration, space was minimal, as 2 mm at least was required for the occlusal only, as authors were already not advising a full coverage restoration. Full cuspal coverage restoration, rather indirect crowns or zirconia crowns or something like that. So in this case, they have done additive composite bonding on the occlusal table of upper first molar, which was opposing the lower first molar, for which we are seeking the treatment. The opposing first molar, second molar, and the premolars were done with additive composite bonding. The OVD was raised, and the additional 1 mm of the space was gained. So less tissue of that root canal treated tooth was sacrificed. And occlusal only, as you can see in this photo, which is just for reference, was provided. And then they have addressed some concern which are worth mentioning here, that CAD CAM scanning requires the scanner to be seated. For the CAD CAM scanner to be seated, it requires preparation of 1 millimeter of chamfer around all the crown margins, necessitating more removal of the dental capital. And they have mentioned that cosmetic dentists overprescribe the white restorations such as zirconia and EFM crowns, causing loss of more dental tissue. And full coverage crown should be used sparingly. Functionally generated pathway technique, as explained by Myers, was discussed in scenario 3. It is basically when you are doing a temporary restoration, you should mix the temporary restoration material, put it into the preparation, and when it is in doughy consistency, cover it with a separating medium and let the patient move his mandible or lower jaw or the opposing lower jaw into all laterally directed or anteriorly directed movements. So the pathway of the movement of the tooth will be generated before the material is being set. Then it is polished, and there you have your functionally generated pathway restoration. So there is no need for impression or getting a wax bite or something like this. Thank you for staying with us and listening to me. Do share and comment on this video if you find anything that is not not clear to you.